How do you define a multi-ligament knee injury? We've heard a lot about the ACL and the excellent sessions we've had earlier. The definition is, unsurprisingly, 2 or more injuries of the ACL, PCL. Now, rather than calling it the MCL, we're going to get an excellent lecture of the posteromedial corner, because there's a lot more to the medial side than just the MCL, and of course the intricacies of the posterolateral corner, which also include the LCL. So you need 2 or more of these to then qualify as that multi-ligament. Now, classification systems are good if they are reproducible, easy to remember, and help inform treatment decision-making. The most commonly quoted classification for knee dislocations is that of Schenck. This is almost 20 years old now, but it's still commonly referred to in the literature. What is good about it is it includes all the ligaments, the ACL, PCL, and the collateral ligaments. What is also good about it is that not just the ligaments get injured, sometimes with an associated fracture. It includes that. What it's also good about it is that it also includes arterial injuries and nerve injuries. This is excellent. What's the limitation of it? Meniscus tears are also important in managing these, and articular cartilage lesions are also important. However, if you make a classification system too complicated, they'll either not be used or be misused. But overall, this is a commonly used classification in the literature. Now, investigating the patient who's come in with a dislocated knee. Hopefully, the diagnosis is very clear on physical examination when you physically see the patient, the rather deformed leg. But quite often, the plain X-ray is taken so you can appreciate whether it's an anterior posterior dislocation. That can help inform how you best reduce the knee. An MRI scan, of course, is important because it gives you all the information of which ligamentous structures are involved. But what is super important, and if you're going to remember one thing from this talk, remember this. 40% of knee dislocations are associated with a vascular injury. Miss this, and you're in a lot of trouble. I have a low threshold for doing a CT angiogram or getting a vascular surgeon involved, but you absolutely must make sure that not just palping pedal pulses or I'm off to get a Doppler ultrasound, see if it works. If you can't feel it very good, there's most likely a serious problem, have a low threshold for a CT angiogram. Now, when a patient's had a knee dislocation, they're not going to let you examine them very well in A&E, in the resus department, because their knee is very sore, very swollen. It's not like in an elective clinic. So another way of getting some fruitful, meaningful information from an examination, certainly for me, is an examination under anaesthesia. And one thing that I have also found is examination under fluoroscopy. And when you do stress radiographs, you can see that with it's in neutral and with its stress, you can see it starting to gape. We quantify it as being abnormal. There's 3 millimeters or more of increased laxity or gaping of the joint space, certainly compared to the contralateral knee. But examination under anaesthesia in these cases, under fluoroscopy, I find is very, very useful. But what is very, very important is you absolutely need to document your physical examination findings. Sometimes there's an intimal tear of the popliteal artery. On an initial presentation A&E, the pulse may be okay in the foot. That intimal tear of the artery can progress and dissect and cause further occlusion. Re-examination is important. There might be foot drop, common peroneal nerve injury might have happened at the time of injury. You need to document these things. It's very important before and re-examining afterwards. Super important. Now, after you've reduced it, by and large, most of them will stay reduced, but on rare occasions, the knee is ridiculously unstable and keeps dislocating. There are rare occasions where an external fixator is indicated to try and keep the knee in joint, or at least have a degree of congruity. Now, things like if there's a vascular injury and the vascular surgeon is wanting to get in there, but he's wanting some degree of stability there, you can put in X-fix. If it's an open injury, or a number of other indications. If you are going to put, on the rare occasions, an X-fix, make sure that the pins are far away from where the intended area of surgery is going to be. Pins can and often do get colonized with bacteria. If you put one of your pins for your X-fix very close to the actual joint, you colonize that area, and then the knee surgeon doing the reconstruction later is not going to thank you when you increase the risk of septic arthritis following surgery. So there are rare occasions where an X-fix is needed. by and large, most of the time, when you do reduce it, you can't control it for the immediate first aid part of it with a back slab or a knee splint, again, having good access to the foot to check distal neurovascular supply. So that's by and large your first aid element of it. Now, in terms of treatment strategies, and these are broad principles, not the fine details you'll get from my co-panelists shortly, we generally accept early intervention is within 3 weeks, 21 days. Of course, getting in early is better for the patient, starts rehabilitation. However, you can't always go in there early. If they're a polytrauma patient, if they're turned in ITU, if they've simply not got the physiological reserve to get there, then you might need to wait a bit. There are various other reasons why having a staged approach that's stated there is also important too. But when you do get in, the priorities are, if there's a vascular injury, that takes priority. That trumps everything. Get the limb revascularized. If there is an associated fracture, you need a stable bony base to fix the fracture before you then intervene with the ligament reconstructions and also be tentative to the meniscus and cartilage injury. Common peroneal nerve injury, more often than not, is a neuropraxia most of the time. You might need nerve conduction studies and EMGs later on down the line to confirm that. In whatever region you work, know who does peripheral nerve injuries. Up in the northeast, our peripheral nerve injuries are managed by plastic surgeons. Of course, in London, a lot of them will go to Stanmore with the orthopaedic team who do peripheral nerve injuries. But know who is around you because there will be other people involved in the overall totality management of these patients. This is the most recent publication. It's barely 6 weeks old on the topic of multi-ligament knee injuries. We've heard about consensus statements and Delphi processes are becoming a lot more commonplace, where you get a lot of people who are super specialists in this field and you ask their opinions on certain things. So one of the things that Jim asked me to discuss is whether we should be doing these things as single stage or as a staged procedure. Their recommendation is, where possible, do everything in a one-er. That's not always possible. There will be a number of cases where a staged procedure is indicated depending on the severity of the injury, concurrent injuries, and the personal algorithms that the individual surgeon wishes to follow. So each case needs to be followed on a case-by-case basis. So in conclusion, multiligament knee injuries are complex injuries. You absolutely need to have a holistic approach. It's major surgery. Clinical acumen, your physical examination is super important. Your radiological examination is an adjunct. Please remember to evaluate the vascular supply. And your priorities of treatment is as stated, where the vascular surgeons go in first, fix the fracture, then the ligaments.